يعني حدا بيعرف how to fix الفلاش درايفنج الكمبيوتر مش عم يتعرف عليها؟ Can anyone fix this? That's not a jump bar. Don't sit next to each other, please. Keep a distance. Can anyone fix this? Okay, so last time we started talking about rheumatoid arthritis and what is the pathophysiology of the disease. What's the problem in RA? It is an autoimmune disease and it will result in inflammation, damage to what? What is the tissue? Keep distance, please. Skip a chair. Damage to what? To joints. So the attack is on the joints, right? The damage is on the joints. And we said that we have 3 groups of drug therapy that can be used, which are yes, very good. So DMARDs, NSAIDs, and glucocorticoids. And when we talked about NSAIDs and glucocorticoids, where they come in therapy, can we use them for chronic treatment? So to relieve acute attacks, or we call it disease flare. What does it mean, flare? No. Bridging is we use it till the DMARD is in action, right? But we can use them, steroids and NSAIDs, to control disease flares. What does it mean, disease flare? What does it mean?
Relapse
No, flare is not relapse. Disease flare means what?
Not correct.
Pardon?
Not correct.
Flare means a deviation from normal pattern. So for example, if there is an RA patient, regularly he wakes up in the morning, some stiffness, a little pain, but one day stiffness was increased, more joints were inflamed. What does that mean? A deviation from the normal pattern, right? We call this flare. So, to manage acute symptoms when we have disease flare, we can add what to our DMARD therapy?
NSAID or corticosteroids.
NSAIDs or steroids, right? So can we use NSAIDs as monotherapy? No, we have to add them. We call this adjunct, okay? But glucocorticoids can be used to manage acute symptoms and disease flares, can be added to DMARDs. We can use them either systematically or we can use them oral IV systematically, or we can inject where? To the joint. We call this what? Intra-articular, right? To inject the drug into the joint, into the synovial fluid. When we can use steroids as intra-articular, but not oral or IV.
لما يكون localized يعني الانفلاميشن بس عنده بجوينت واحد أو
Yes, very good. If we have very few number of joints involved, especially if the joint is what? Big joint. So if we have big joints and few joints, you can then give the steroid intra-articular. Do we have a limit to the number of injecting the same joint? Can we just keep injecting the same joint over and over? There is a limit. How many times you can inject the same joint with intra-articular treatment? Injection into the joint itself, the injection can cause damage to the joint. So we can do that, but we have a limit. Okay, we have a limit. And we explained why steroids particularly are very good. Yes. Immunosuppressive. They suppress mainly which kind of immune cells? Lymphocytes. So they have suppression, very powerful inhibition over the activity of B and T cells. And that's why they are very good in treatment, not only of RA. We'll talk about them when we talk of leukemia and lymphoma as well. Okay? And then we talked about DMARDs. We said that we have two groups, non-biologics and biologics. And we said that we have in non-biologics first-line drugs and third or last line, right? And biologics divided into two groups, which are anti-TNF inhibitors. These drugs target TNF, and non-anti-TNF inhibitors, they have other targets. Okay? Now, we will start to talk about the DMARDs one by one, and at the end, we will discuss the algorithm. In your book, they put the algorithm first and discuss the drug therapy last. I will do the opposite. Okay? Now, we will start with methotrexate. How methotrexate is actually working? Mechanism of action of methotrexate. It's an antifolate. What else? How it is useful in treatment of RA patients? Yes? سلايدات ما في للكل لأنه الفلاش درايف مش شغال. Can you hear me online? سامعيني online? Online, can you hear me? طلاب الأونلاين؟ طلاب online, can you hear me? سامعيني هلا؟ سامعيني هلا؟ طلاب online, can you hear me? طلاب online, can you hear me? Okay. إذا methotrexate how it is working?
الدكتور ممكن تعملي يمكن ميوت لهذا.
How it is working? Antifolate and yeah, how it produces immunosuppressive activity in methotrexate.
inhibits purine biosynthesis.
Inhibits purine synthesis and interleukin activation of lymphocytes, which is very important when we talk about autoimmunity. Okay. What makes methotrexate the first line drug among the first line non-biologic DMARDs? How many non-biologic DMARDs we have as first line? 4, which are methotrexate, sulfasalazine, diflunomide, hydroxychloroquine. So among these 4 drugs in the first line non-biologic DMARDs, methotrexate is the first line. Why? It's the first choice. very good long-term experience. We have very good data about toxicity, safety, efficacy. What else?
Yeah, the fastest onset.
Yeah, we said that generally DMARDs have late onset, right? But among these, methotrexate has the fastest onset. اطلعوا برا انكم مش حاطين الكمامة الصبايا. أنا ما راح أقول حط الكمامة. اللي ما بيحط اطلع برا. شو the onset of action? What's the onset of action?
2 to 3 weeks.
Within 3 weeks, maybe 4 weeks, we expect to start to see effect. Okay? So, relatively speaking, with other DMARDs, it has an earlier onset of action, which makes it very appealing drug. Can we combine methotrexate with other non-biologic DMARDs? Yes, and we have how many combinations? Dual combinations, 2 drugs, and triple combination. So we can add methotrexate with eflonamide or sulfasalazine or hydroxychloroquine. And we can have a triple combination, methotrexate plus 2 other non-biologic DMARDs. And we usually start dual or triple combination if the disease is
severe,
moderate to high severity, or very reactive disease. Okay? What is the major toxicity of methotrexate? I talk about methotrexate toxicity. It's not really, it can happen. It's not considered like a major toxicity. Why? Folate deficiency can happen, and if folate deficiency happens, what will happen? What will result? Megaloplastic anemia, right? But we can control this. How? Supplementation of what? Of folic acid, right? So we can manage this. Other toxicities, GRT, what can happen? Nausea, vomiting, diarrhea. What else?
Stomatitis.
Stomatitis.
Flare of the infections.
Stomatitis. What does it mean, stomatitis?
Inflammation of the stomach. Inflammation of the stomach, lining the stomach.
No, stomatitis, not gastritis. Gastritis, inflammation of the wall of the stomach. Stomatitis, where is the inflammation? Oral cavity, oral mucosa. And this is really bad. Why? It can be sometimes painful. Why? Patient will not be able to eat. When we talk about cancer, many chemotherapeutic drugs cause stomatitis. This is really painful. So it's toxic to GI, can cause stomatitis, nausea, vomiting, diarrhea, and it can cause what other toxicity? Hepatic. Methotrexate is hepatotoxic. So what we need to monitor, we are doing liver function test, okay? LFT, liver function test. We need a baseline and we need to follow up. What does it mean, baseline?
Before giving
Yes, you get the data before you start your treatment. And this will be what? Our reference, right? So the baseline is you get all labs investigations before you start the treatment. And after you start the treatment, you need to do follow-up. So when we take a baseline, we look at transaminases, ALT, AST, right? When we have to stop methotrexate therapy, when we need to be careful that here, now, the elevation is a lot and we have to stop. DC means stop. DC, stop methotrexate. If the liver is increased above 2 times of what? Upper normal. For example, if ALT normal range, for example, is 0 to 100 units per liter, for example, and we started methotrexate. After 3 weeks, 4 weeks, we found that the liver increased to 150. Baseline كان مثلا 40. Started to 150. Do we need to stop?
No.
Methotrexate here? Yes or no?
ايش
Is this 2 times upper normal?
No.
Upper normal 100. Elevated to 150. Is this 2 times upper
No.
normal? Okay.
210.
If it was elevated to 250, is this 2 times upper normal?
Yes.
Yes. So here, what we need to do,
Stop.
DC, stop the drug, hold the drug. Otherwise, it causes severe hepatotoxicity. So methotrexate is hepatotoxic. Methotrexate is hepatotoxic. Okay, what else? Pulmonary. What can happen? 2 things. Fibrosis or pneumonitis. Inflammation of the lung, parenchyma, or fibrosis. The normal parenchyma becomes fibrotic, non-functional, and this is really serious, but rare. It's rare, but serious. So when we do follow-up, we need to put 2 things in mind. The common, you have to follow up for the common, and for the rare but life-threatening. Okay? So pulmonary toxicity can happen, and we have to follow up with the patient. Okay, we have this drug as immunosuppressive therapy. What can we see on CBC, for example? What? Leukopenia. What does it mean? What is leukopenia? Drop in what? Leukocyte count, right? Leukopenia is a drop in leukocyte count. And back? Drop in leukocyte count, right? Why this is important? What can happen? If the neutrophil count drops, if lymphocyte count drops, what can happen? The patient becomes what? Immunocompromised, right? And so this increases the risk of what? Infections. So leukopenia can happen because the drug is potentially immunosuppressive. Thrombocytopenia can also happen. What does it mean? Thrombocytopenia. A drop in what? Platelet count. And so there is a risk of what? Bleed. Okay? So if we give methotrexate, we have to monitor complete blood counts, leukocyte counts, hepatic function, pulmonary function, GIT toxicity. So the drug is potentially what? Toxic. Okay? Now, we said that methotrexate is usually your first choice to go for. When methotrexate cannot be used, contraindications. What does it mean, contraindication? Contraindication means what? Never ever use the drug under any circumstances. Okay? Contraindicated. In your book, there is like, I think, 10 different contraindications. So it's a paragraph in your book, go and read it. Okay? If methotrexate is not available, what could be a good next choice? Usually it's flunomide. Okay? So if methotrexate is not there, the flunomide produces a very similar activity to methotrexate, and we can use it. It inhibits DNA synthesis, immunosuppressive drug. However, it also, the flunomide is what? Hepatotoxic. So in case we decide to combine methotrexate and the flunomide, toxicity to the liver will increase, so we have to be much more careful. Okay? If we combine methotrexate and metformin. These 2 drugs are potentially teratogenic. What does it mean? What does it mean, teratogenicity? Toxicity to what? Yeah, because if we give these drugs to a pregnant woman, what will happen? Embryonic toxicity, right? malformation. So these drugs are what? Teratogenic. Okay? Now, the third drug on the list of the non-biologic DMARDs is hydroxychloroquine. Basically, this drug is indicated to treat what? Malaria. It's anti-malarial, right? However, it has immunosuppressive activity and is a DMARD by definition. Where we can use hydroxychloroquine? It's the first line, but it can be reserved for what kind of patients?
الناس اللي عندهم liver damage hepatic damage.
Okay, we are concerned of severe hepatotoxicity. Severe hepatotoxicity or severe liver damage is one contraindication to the methotrexate therapy, by the way. Or in patients with mild disease. RA patient, mild disease, okay? You can start with hydroxychloroquine. Now we said that all in all, it's always recommended to start what? Methotrexate. In mild disease, if you start hydroxychloroquine, it's okay. It's okay. One limitation to hydroxychloroquine is delayed onset. It means like 2 months. Very delayed compared to methotrexate, for example. And to complete the trial before we decide the drug is active or not, we need 6 months of treatment. Okay? So it has a really delayed onset of action. Side effect profile. Pardon? Very good. Skin toxicity, not pigmentation. Sulfasalazine, 100% pigmentation. Can cause rash. If patients use hydroxychloroquine, recommended not to be exposed to UV. Okay? What else? Very important toxicity.
Retinopathy.
Ocular. Very good. What can happen? If you give the drug, it can deposit, precipitate in the cornea. And some patient will have ophthalmic toxicity. Like what?
Blurred vision.
Pardon? Blurred vision. Yes, good. What else? Scotomata. What does it mean, scotomata? Spots, colored spots in the visual field. And third, night vision. Or they have kind of night blindness. So, the bottom line, if you start hydroxychloroquine, what counseling you should give to the patient? Very important counseling point. What should we tell the patient? Yes? Any visual toxicity must be directly reported. Do not ignore. This might indicate toxicity of the drug. Okay? With hydroxychloroquine. Report any visual toxicity. Okay. Next, on the first line DMARDs, non-biologics, we have sulfasalazine. This is a prodrug. What does it mean? Not active. Period?
It will
Not active?
not
Not active unless what?
metabolism
Unless biotransformation takes place on the drug. So itself is not active because it's a prodrug and it needs activation. How sulfasalazine is activated? Transformation takes place where? In lower GI. Who is responsible for the activation?
bacteria.
Bacteria. Your normal flora in the gut. Breaks sulfasalazine into 2 compounds. One of them is the salsalate. And salsalates produce what? Anti-inflammatory activity. Okay? Now, this is a first-line DMARD, and it can be used in combination with other DMARDs taken orally. What is the most important toxicity? It's a sulfur drug, so it can cause what?
Allergic reaction.
Yes, but let's talk first, yes, good, but let's talk first about self-allergy. So, the drug itself can cause toxicity, hypersensitivity, or it might be aggravating toxicity other subtypes. Okay? What else? Urine and skin discoloration, a change in the skin color or urine color. To what color? When we counsel the patient, what we tell the patient? Yellow, orange, dark. Okay? So this can happen because of the drug. Is this alarming? Does this mean that you have to stop the drug? No, it's not. It's not something alarming, but the patient must be aware discoloration can happen, but it's okay, just because of the drug. Okay? What else? It can cause leukemia. Okay? So, before first line non-biologic DMARDs, they are usually your first choice in antibiotic treatment. Among these, methotrexate is preferred if we have no contraindications. You can then, if methotrexate is not active enough, add or switch. You can. Okay? Now, when we talk about biologics, we said based on the target, we have divided them into anti-TNF, target is TNF, and non-anti-TNF, right? So anti-TNF, non-anti-TNF, by definition, these are what? Biologics. There is one drug, we call it, its name, tofacitinib. This drug is not classified, does not belong to the group of non-biologics, and it is not a biologic. It stands alone. This is a novel mechanism. This drug is a Janus kinase inhibitor. Okay? Janus kinases are coupled to what kind of receptors? Cytokine receptors, right? Cytokine receptors, examples of their ligands. No, they are not tyrosine kinases. Janus kinase is a tyrosine kinase, but the cytokine receptor itself. Give me ligands. Why inhibiting Janus kinase, stopping activation of cytokine receptor is good when we treat RA? What's the type of TNF receptor? TNF receptor belongs to what kind of receptors? Cytokine. Interleukins. Cytokine. So if we inhibit TNF receptor or interleukin receptor, very important inflammatory mediators when we talk about RA. Can TNF interleukin produce inflammation? No. So basically, okay, this is the cytokine receptor. The Janus kinase is coupled here. If Janus kinase is not active, the cytokine receptor is not active even if the receptor is bound to its ligand. So even if TNF is bound to its TNF receptor or interleukin is bound to the interleukin receptor, if we inhibit the Janus kinase, you cannot activate inflammation in this pathway. So tofacitinib is a Janus kinase inhibitor. Very novel. It can be used alone, it can be added to non-biologic DMARDs, but it's not one of our first or second line choices because it's toxic. It can cause what? All DMARDs, biologics, cause immunosuppression, and so they can increase risk of infections. But something special about tofacitinib. Lymphoproliferative malignancies like lymphoma. Why? If you suppress your immune system very powerfully, very strong suppression, can your immune cells catch, detect, attack immune cell, active growing cancer cells? No. So biologics and tofacitinib increase the risk of malignancies, particularly lymphomas, leukemias. Okay? Particularly. And for that, we have to be very careful when we add castellanate to the treatment. Usually for patients not responding to other biologics or to combination of biologics and non-biologics because of this toxicity. However, it has a novel mechanism of action. Okay? Now, let's go back to biologics. TNF inhibitors, they bind TNF. To stop TNF, TNF is a very inflammatory mediator. If you stop TNF, bind, capture TNF, you neutralize the molecule. It cannot bind its own receptor, cannot cause inflammation. Okay? Now, the anti-TNF as a group, we have precautions. And it's recommended not to use in certain populations, in certain patients. Like what? In patients with heart failure. Which patients with heart failure? 3 and 4. So, stage 3 or stage 4 symptomatic heart failure patients, we do not start or add what? Here we talk about anti-TNF. Why? Because they can deteriorate the condition and even cause more and more drop in ejection fraction. Okay, can we add anti-TNF inhibitor to a patient with RA stage 1 or 2 heart failure? You can, but you have to be very careful. That is a precaution. But stage 3 and 4 heart failure, do not use anti-TNF biologics. So if we need to add a biologic in such a patient, we can go to what? To non-anti-TNF, right? To a non-anti-TNF. But anti-TNF, don't use. The other group of patients where we cannot start TNF inhibitors are patients with multiple sclerosis, MS. What happens in patients with multiple sclerosis?
autoimmune disease.
It attacks what?
المايلين شيت على
The nerves, the myelin sheet. So it's a neurological problem, right? Now, TNF inhibitors deteriorate MS symptoms and cause the disease to progress. And so we should not add TNF inhibitors to patients who have a diagnosis of MS, multiple sclerosis. Okay. What is in general the risk of TNF inhibitors in patients using them on long-term blood cancers, lymphomas, leukemias? They increase this. And so we have to be very careful. So TNF inhibitors increase the risk of lymphoproliferative malignancies like lymphoma, lymphocyte leukemias, and so on. Now, before we can use biologics or the groups, we need to make a test. We call it tubercular skin test. Why? Of what? Reactivation of what? Okay. What does it mean? Latent infection. If I say that patient X has latent tuberculosis, latent means what? No. Latent TB.
يعني
latent hepatitis.
بيكون نورمال بس ممكن انه يصير لقدام يعني معه.
Precisely. What does it mean, latent infection? Does the patient carry the microorganism?
Yes. بس ما
Is it in the biological system?
Yes.
Yes. Is this causing an active infection or symptoms? Is
No.
the patient clinically has symptoms of hepatitis, TB?
No.
No. Why?
مش active.
because your immune system is suppressing the infection. So the patient is a carrier of the microorganism but is not symptomatic. If you inhibit the immune activity with very powerful drugs like biologics, you can reactivate the latent infection. And so patient now can actually have active TB, active hepatitis. So we do, before we start biologics, this is true to both groups, TNF inhibitors, non-TNF inhibitors, both groups. Before we start biologics, we have to rule out, what does it mean rule out? Yes, make sure the patient does not have latent TB. Okay? We have to rule out latent TB. Now, with some biologics like rituximab, an anti-TNF inhibitor we will talk about, you also have to rule out hepatitis B, latent infection. So, in certain biologics, you have to think of other latent infections, but with all biologics, we have to rule out what? Latent TB. Okay? Now, we'll start with drugs, TNF inhibitors.
latent TB ارجع لي latent TB.
Latent TB? What's wrong with latent TB? If the patient has latent TB and we give biologics, it becomes active TB, active infection. It's like you cause TB to the patient. It could be fatal. So, we do the skin test, tuberculin. Negative, it means that the patient does not have latent infection. It's okay. It's safe to go with a biologic. But if it was positive, the patient is a carrier of TB, but asymptomatic, latent. You should not start biologics. Okay? So this is done before treatment. Negative, non-latent infection, it's okay. Go ahead with a biologic. Positive test, hold, do not give biologics. Okay? Now, according to the structure and activity, we have three main groups of anti-TNF inhibitors. Okay? A drug called infliximab, adalimumab, and etanercept. Have you heard of infliximab before? Yes. What's this drug? They are all anti-TNF. They all bind, their target is what? Is what? TNF itself, right? These are antibodies. So, what is the antigen here? This is the antibody. What's the antigen? TNF. So, the target is TNF. If you give infliximab, the drug, the antibody, is an antibody, it will bind TNF. When it binds TNF, is TNF now free to go bind its receptor? No. So basically, what did we do? We neutralize the molecule. It's not available anymore to bind its receptor. We stop its action. Is this binding between the antigen and the antibody reversible? No, it's stable. It's not reversible. So we decrease availability of TNF in the inflammation site to bind its receptor and cause inflammation. That's the idea when we give TNF inhibitors. Okay, infliximab is a monoclonal antibody. Adalimumab is a monoclonal antibody. Both are anti-TNF. How they are different?
chimeric مورين.
Chimeric and
مورين.
humanized. What does it mean, chimeric antibody?
بنفع قديش في المورين بارت من الانتي بودي.
Pardon?
الماوس بارت قديش في ماوس بارت بالانتي بودي. هون 75.
Precisely. Yes. Excellent. The variable region. This is constant region or variable here?
Constant.
This is constant, FC, right? This is the variable region. What region binds your antigen? The variable, right? So, in the chimeric antibodies, the variable region is not purely human. So when it is chimeric, some regions here are of mouse origin. But in the humanized antibody, the variable region is completely human. There is no mouse variable region or sequences. So, what is the main difference between these two antibodies? Exactly. Yes. Yes, very good. If we give infliximab to the patient, it contains non-human regions, peptides.
Immunoreaction.
Your immune system will assume this is what? Therapy. And it will attack infliximab, right? So infliximab is potentially what? Immunogenic, right? If you give infliximab without immunosuppressive therapy, 40%, maybe 60% of patients develop antibodies against what?
The drug.
Infliximab itself. Okay? Your immune system thinks of infliximab as foreign molecule because this is variable mouse region. And your immune cells, your B cells, plasma cells produce antibodies to attack infliximab. And infliximab is not active, right? So what should we do? We have to give immunosuppressive therapy to stop this reaction. What is the ideal drug to give with infliximab?
Methotrexate.
Methotrexate. So methotrexate is a must when you give what? Infliximab. You don't have a choice. You have to. You must combine methotrexate with infliximab. In what dose, in what regimen, we have to add methotrexate to infliximab. In the regular doses we give in RA patients. How we give methotrexate, by the way, I'll skip the dosing. How can we give methotrexate to the patient? Orally, parenterally, IV, daily, weekly. So orally available, subcute, IM. You can give it IM, subcute, oral. You can give it daily or weekly doses. If the dose is big, above 15 milligrams per week, it's recommended to give that methotrexate parenterally. Otherwise, absorption is impaired. So, if we give infliximab, combine a regular oral dose of methotrexate with infliximab, and you must do not only for RA but also to suppress immune reaction to infliximab because it's chimeric. Now, how infliximab is given? How we give infliximab to the patient? IV infusion. These are peptides, okay? These two. Now, adalimumab and the other humanized can also be given subcute, and this is an advantage over infliximab, okay? Now, what toxicity can happen when you start IV infusion?
Rash.
It's potentially immunogenic, right? Okay, infusion-related reactions. So, commonly, if you give infliximab, patients develop infusion-related reaction. What will happen? Once you start infliximab infusion, after some time, it could be, by the way, the reactions could be either acute, happens within 24 hours of infusion. It could be delayed, can happen up to 14 days after infusion. What will the patient feel? How we know the patient developed infusion-related reactions?
Chills, fever.
Chills, excellent. Fever. They start to chill. You touch them, they are warm, fever, sometimes pain, okay, fatigue, weakness. Now, this commonly happens. What can we do to prevent the infusion-related reactions? Stop. Slow. If you give slow infusion, extend the time of infusion. Okay? The incidence decrease. Is that enough? It's not enough. What should we do? What should we do also? Administration of? When? How? What we call this?
Symptomatic relief.
To pre-medicate. What does it mean to pre-medicate?
يعني
Before we start the infusion, we want to give a treatment to prevent or at least control the reaction. So what is the classical combo here? Classical combination, 3 drugs. Pre-medication to control decrease infusion-related reactions. What should we give? Acetaminophen, right? Excellent. Steroid and the third drug.
Diphenhydramine, antihistamine.
Steroid. What? Antihistamine. Diphenhydramine. Or hypersensitivity. So usually, when the patient comes, we want to start our infusion infliximab. Before we start, we give acetaminophen, glucocorticoid, usually other cortisone, dexamethasone, and anti-H1, like diphenhydramine, for example. Then, 30 minutes later, we start what? Our IV infusion. In this case, we can control the infusion-related reactions. And these can happen within 24 hours, acute onset, or up to 14 days. So, after the patient actually finished the infusion, leave, go to outpatient, go home, the risk is there. That you have fever, fatigue, chills, and you have to come to hospital. Okay? Or medicate outside, it depends. Okay. Etanercept is an anti-TNF. How it works, it's not a monoclonal antibody actually. It's a trap. شو يعني trap? It's a trap. It's not a full monoclonal antibody.
شلنا منه الريجن.
This region here is what basically? Etanercept. Did you hear this drug before? It's a trap. It binds, this region will bind TNF because this region is what? It's a receptor. It's a part of the TNF receptor. Okay? So we call it a fusion protein or a trap. Okay? It's not a full antibody. Now, etanercept is an anti-TNF. It can be given among the first line anti-TNF drugs. It's also given subcute. Okay? Now, adalimumab, golimumab and drugs, the humanized anti-TNF, they all share the same precautions toxicity. In other words, chimeric, humanized, fusion protein of trust, they all have the same issues. They all have the same potential side effects, toxicity. Okay? Contraindicated in stage 3-4, heart failure, in MS, they can cause lymphoproliferative disease. But they are a little bit different in tolerance, because this is a humanized. This is IV, these are can be given subcutaneous. Otherwise, they have very common things. Okay? Questions about anti-TNF? If we start infliximab or adalimumab or etanercept and the patient did not respond, can we live? Can we shift? Can one anti-TNF to the other?
Yes.
Or if failure to adalimumab, then don't try infliximab, don't try etanercept. What do you think? Can we?
Yeah.
Yes, we can. We'll talk about the algorithm. Okay. Now, one drug, a non-anti-TNF biologic, is called abatacept. Have you heard of the concept about immune system and cancers, immune checkpoint inhibitors? Have you heard about the last year's Nobel Prize in Physiology and Medicine? مين أخذ النوبل Prize? Japanese professor and American professor. Have you follow this? For discovery of immune checkpoints. Have you heard that? CTLA4 inhibitors, PD-L1 inhibitors. Okay. In immunology, what is the most important type of cells to destroy infected tissue or cancer cells?
T cells.
What T cell? We have helper T cell, regulatory T cell, cytotoxic T cell. What T cell attacks the tissue?
Toxic.
Who is not, who does not talk or register immunology? You all have the course? Immunology. You all have the course? Cytotoxic T cells is what? CD8 positive, right? Now, cytotoxic T cells, once activated, it attacks infected tissue or cancer cells. Now, immunotherapy in cancer, the theory that cancer cells will grow because the immune cells are inactive. The immune cells are unable to recognize and attack. Now, every day when your normal cells divide, there are genetic errors. Every day cancer cells are formed, but they are not allowed to survive and they grow. Why? Because your immune system will find them and attack them. Through what? Activation of cytotoxic T lymphocytes. To activate cytotoxic T lymphocytes, we need what? Antigen-presenting cells. Right? So, antigen-presenting cells present the antigen, bind to the T cell receptor, activate T cells start to proliferate, and then they start to attack. Now, if we block the interaction between antigen-presenting cells and T cells, can T cells be activated?
No.
No. Okay. To this point, is this good or bad to treat autoimmunity? Autoimmunity. When we stop T cell activation to treat autoimmunity, is this something good or bad?
Good بس راح يعمل لي مشاكل ثانية.
To treat autoimmune disease like RA, we said already that T cell, B cell are
Overactive.
counteractive. block. Is it good for autoimmunity or bad?
Good. Good بس راح يعمل
For autoimmunity. Do we need to activate T cells or suppress T cells if we have autoimmune disease?
suppress them.
Suppress. They are already active, right? We want to suppress. So, abatacept binds a receptor, CD80, on antigen-presenting cells. Okay? By binding to that receptor, antigen-presenting cell cannot activate T cells. So, if we give abatacept, what will happen? The ultimate effect of the drug is what?
suppress the immunity.
Decrease the activity of T cells, and so immunosuppressive drug. انت مبارك كان اول مره انا مطرحك بطفي بعمله سايلنت بعمله بايبريتنج صح ولا لا؟ صح؟ قولوا صح. شو هنعمل كده؟ غيرها. So, if we want to treat autoimmune disease with hyperactive, above normal activity of T cell, we want to stop, not to suppress T cell, and so abatacept is one option. However, we said when we use biologics and when we inhibit B cell or T cell activity, there is a risk of what? Cancer, lymphoproliferative tumors. Okay? Clear? So abatacept is a non-anti-TNF biologic. Generally speaking, if you want to start with a biologic, do we start with anti-TNF inhibitors or non-anti-TNF?
لا أنت المالجنانس أكثر مع
Biologic. We start with anti-TNF. For example, I want to add a biologic to my methotrexate. I should go first with infliximab, etanercept, or I should skip and go to abatacept, rituximab, go to
anti-TNF.
We start usually at anti-TNF. Anti-TNF is usually the biologic to start with. We recommend to start with anti-TNF drugs. Okay? So usually abatacept is an option, but you can usually try after anti-TNF inhibitors, especially if they do not improve the case, because this is very immunosuppressive drug. Okay. We will stop here.
دكتور بدي أسألك هلا بناء على هاي الباثوفيسيولوجي هل هذا يعني الناس اللي عندهم اوتو اميون يعني اميون ديزيز بيكونوا اقل عرضه للكانسر؟
It depends. Not necessarily. Not necessarily. لأن هون attack selective. They are attacking your joint, not attacking cancer cells. Cancer cells hide
يعني أنا لما مثلا أعطي هاي الأشياء on V أو
هو أنت بتتحول ل generalized autoimmunity. يعني إحنا ال RA it starts with the blood, but it can then expand. Not necessarily. Okay. توزع عشان توزع. There will be a first out now. Turn off your cell phones. Distribute over the room. Distribute. عبر المقاعد مثلا. Distribute over the room, please. وزعوا. يعني عبوني هون. تتأخروا القاعة. بتعبوا المقاعد بتحموا تطلعوا كثير بالفورية. تتأخروا بالطلعة. عبوا المقاعد الأمامية إذا بتريدوا. بليز عبوا المقاعد الأمامية. هوزع answer sheet. Write your name please on the answer sheet. You all have your answer sheet. Write your name, your ID, please. 9, 11, 15. الصبايا اللي على الخط يعني حق بعض. Yes, you move. زادوا لنا please. Okay, all of you have your name ID. This is section 2, quiz 1. Okay, section 2, quiz 1. You all, في حدا ما أخذ ورقة؟ Why?
وهون دكتورة
مين ما أخذ كمان؟ مين ما أخذ؟ نزلنا هلا. سؤال بسيط يعني مرة أبدا. شوف. إذا الكويز ما بيمشي in a decent way, I will cancel the quiz day وبطلع معك. نقعد نحكي مع بعض، نطلع على بعض. ما حد زعلان بوينت سؤال، حكينا. فإذا بحس إنه السيتنجز are not good، خمس علامات تمتحنوا فيهم بالنت. هاي العلامات لحتى تساعدكم. أوكي؟ فهلا بتشوف بحكي السؤال، بتجاوبون نص دقيقة. You put down your pencils and the papers from back to front. حركة كتير ودوشة، حدا قاعد حدا قاعد. صدقوني إذا حسيت إنه it's not good enough بلغيه. Okay? طيب, the question is حدا ما أخذ ورقة. You all got it? Mention a condition where anti-TNF biologics are contraindicated. One condition where you should not start anti-TNF biologics. One condition where anti-TNF biologics should not start. One condition. One condition where you should not give the patient or start anti-TNF biologics. One condition where you should not start anti-TNF biologics. Okay? Back to front. ما تتحركوا ما تغيروا أماكنكم بس سلموا بعض. الورق. Middle. Back to front. سلموا بعض الورق. Straight from here. سلموا بعض الورق. Back to front, please. Do not move from your seats. تفضلوا وياه هنيك عند بعض. Back to front. Back to front. Back to front. Sit down, sit down.
ضل حدا؟
Back to front. Why you are moving? Why? مش أنا حكيت خليني أماكنكم. تسلم. صبايا تسلم زميلات هون. The first line. التسلم. التسلم. Okay. شو الإجابة؟ Either stage 3 for heart failure or multiple sclerosis. Right? One of these. Any answer is okay. Is right. Stage 3, 4. If you don't write stage 3 or 4, that's heart failure. No.
لأنه 1 و 2 بيكون
يعني 1 و 2 you can do. Stage 3 or 4 heart failure. 1, 2 you can do with caution. Right. Pay attention please. هلا. Okay, I have to speak most of the class in English because your colleague is from Nigeria, right? Hafsa? Your colleague is from Nigeria. Do you know her?
Yes.
So you live in Nigeria or you buy country? So you come from Nigeria to here. I have collaborators from Ghana. He's a pharmacist, oncology pharmacist. We collaborate. Okay. Now, there will be 5